which I feel is very important in the present scenario now that after neonatology and further down, we are having a lot of babies, high-risk babies who need to be cared for going from neonatology. And I think our country as a whole has to move forward from just saving them to seeing where the development is going wrong. And like we all know, the earlier you catch them, the better the outcomes are. So I will, and to take us through the gentle movement assessment, we have two eminent speakers, Dr. Anjan Bhattacharya and Dr. Joel Chakrabarti. Dr. Anjan is a senior consultant and a developmental pediatrician at Apollo Multispecialty Hospitals, Calcutta. And Dr. Joel Chakrabarti is also has the role of the pediatric physiotherapist at the same hospital, and also the Child Development Center at Apollo Multispecialty, Calcutta. And to moderate the session, we have none other than Dr. Naveen Jain, who has done a lot of work with regard to in the field of development. And I think for people from Kerala will recognize him, his teachings. He's been there for all the conferences. And even Calcutta, I think, sir was having a workshop recently in the recently concluded NeoCon, the last year.
Yeah, maybe.
So without further ado, I will ask Dr. Anjan sir, we can start with the topic. And then further, after each topic, we can have a question answer session, which will be taken up by Dr. Naveen sir.
Thank you. Thank you very much. So in that case, what I would like to do is for our psychologist who coordinates all our academic program at the moment, Megha Goenka, she is also in this meeting, for her to share the slides and do the introduction while Joel joins, because if Joel joins, then he can take it forward, otherwise I will. So in that case, we will need the whole PPT that Megha has, and Megha can share it.
Sure.
Sir, Joel sir is already here with us.
Oh, okay. So why don't you just introduce us and then we can start?
Definitely. So just give me a second. I would like to share the screen.
Or Joel sir can share the screen and then you can do it.
Perfect, perfect.
I think that's best.
Yeah, definitely.
So Joel sir, if you could share your screen, then Megha can introduce both of us and then you can continue.
Yeah, sure. Can you hear me? Am I audible to you?
Yes, sir.
Yeah, this is fine. We can go to the first slide, and then if you put in the presentation mode, Megha can do the introduction.
Yeah.
And then we can move forward.
Yeah, thank you so much. First of all, good evening, everyone. Thank you, everyone, for joining. So today we have two speakers, Dr. Anjan Bhattacharya and Dr. Joel Chakrabarti.
So if Joel could put it on the presentation mode, that would even be better.
Yeah. So just a minute. Is it okay now?
Yeah.
Perfect, sir.
Megha. Yeah, sure.
Yeah. So Dr. Bhattacharya is a senior consultant developmental pediatrician at Apollo Multispecialty Hospital, Kolkata. And he is the person who has started India's first child development center in corporate healthcare sector. And from past 3 years, he has also started one course, postgraduate diploma in early intervention for neurodevelopmental disorders, which is in collaboration with MACAUT, formerly known as West Bengal University of Technology, WBUT, under their CCPTR program. He is the director of the course. And this is India's first course in early intervention in Eastern India. And he is also director of Navajata Child Development Center.
Okay, we can introduce Joel now.
Definitely. Yeah. So Dr. Joel Chakrabarti, he is currently pursuing his PhD. He is a master of physiotherapy. He has lots of certifications and licensing in his area, as you all can see. He is currently associated with CDC Apollo Multispeciality Hospital and also one of the founder director of Navjata Child Development Center. And so can you please change to the another slide? Yeah. And as Dr. Anjan says that he is jewel of our research. You can all see that he is having many contributions in one of from in the research experiences from all around the world. He was collaborator in LEAP-CP study with Queensland University of Australia. He was also co-investigator in ICF cerebral palsy corset validation for Southeast Asia WHO region. He has also presented several posters in the annual conferences of European Academy of Childhood Disability. He was a clinical evaluator in MedSpace PTC Therapeutics DMD randomized clinical trials. And one of his recent achievements, he was a co-site investigator in the Indian validation study of the Bailey's scale of infant and toddlers development, 4th edition with Pearson, India. So, yeah. Thank you.
Thank you, Megha, for this elaborate introduction. And thanks to Dr. Bhattacharya for this opportunity. And I feel privileged to present this with all the doctors and the team members and the audiences. So my fascination with the general movement assessment starts just with the LEAP-CP study, as Megha was mentioning in that research thing. So that in LEAP-CP study, we actually participated in a study with Queensland University, Australia. So where that is all basically early identification and early intervention. So we'll deal with that later if we get opportunity. So I'll concentrate on the today's topic. So that is general movement assessment. Now, from the term itself, you can understand. So we are going to talk about the movements. So there will be few videos, and just for the statutory purpose, I must say that all the videos will be shared here for this presentation. We have taken permission from the parents, and I'll request all the audiences not to record or share these videos with any other purposes. So first, I'll run the videos so for the audiences, so they can see if they can see any differences in the child's movement patterns or the behavior. So this is the first video. This is a child, 12 weeks post-term age. Its corrected age is 12 weeks. Now I will run the second video. This is also 14 weeks child. So there is one video that is normal and another video is abnormal. Obviously, you can see the differences in movement, but can you say which one is normal and which one is abnormal? Okay, so I'll go to my next slide.
So we have some answers in chat.
Yes. Can you read out those things? So I'll concentrate on the presentation.
Definitely, sir. So we have one response from Varun M. Left normal, right abnormal. Second from Dr. Elizabeth. 2 normal from Ajay, right abnormal from Ethan. Second one, Dipanjana Pradhan. Second baby abnormal, second abnormal.
Okay.
Live.
Yes. So before describing what is normal and why it is abnormal, so let us understand how we conclude that this is normal and abnormal. So this general movement, these patterns starts at the fetal stage. Now, in the fetal stage, we see when basically the child is in mother's womb. So we see there are movements start on 7th to 8th week onwards in PMA stage. And there are those movements, these movements are basically called central pattern generator. So now these central pattern generators are basically self-organizing biological neuronal circuits. Those produce rhythmic outputs in the absence of rhythmic input. So these patterns, basically rhythmic motor patterns like walking, breathing, flying, and swimming in the swimming. So this kind of pattern basically shown in this in the fetal stage. And if you have seen any like in ultrasound in the fetal stage, we can see there are movements we call it fetal movements. So initially those movements are basically seen in the means the body, means basically the movements of the limbs. Gradually those movements turn into the whole body movements. And this has been mentioned by the Breschel in 1989. So that is basically, so that normal, that central pattern will be if there is no lesion, means in the normal stage. If there is any lesion in the brain, so that reduces those modulatory input, and that leads to cut the neuronal circuits. So then the central pattern will be abnormal, and thus in that manner only we can see those abnormal movements. So that is why there will be some normal movements, then there will be pattern of abnormal movements. So this is the developmental course of the general movements. So those general movements starts at the fetal stage and in the preterm stage. So till 40 weeks of age, we generally consider in the preterm stage. Then after term, there will be those general movements. If the normal movements or patterns are normal, then we call those breathing movement. And later on, from 12 weeks to 20 weeks of time, we see the movements. Those movements are called fidgety movements. And based on these fidgety movements, we can predict many neurological disorders in the later stage. In case of cerebral palsy, we can identify with 98% accuracy, and in other neurocognitive disability with 67 to 68% accuracy. But these fidgety movements generally arise 12 weeks at the corrected age, and those last till 20 weeks, means till 5 months of age, corrected age. And after 5 months, we see the normal, generally other other movements. Those are normal kind of pattern movements like rolling and other movements, swipe movement. Those movements takes on the fidgety movement. So that's why the importance of this GM assessment is basically up to 5 months of age after birth. These general movements involve the whole body in a variable sequence of arm, leg, neck, and the trunk movements. And these general movements assessment basically based on the gestalt perception. Means whatever movements we see in the child, we never concentrate on any particular portion, like neither only on the arm or leg or neck or trunk. We see the whole pattern of movement as a whole unit, not the isolated part. And those movements have rich repertoire. Means the pattern of movements will be rich. So there will be a component of elegance. Those movements gradually, there will be gradual onset and gradual offset of the movements. And we call those the waxing and waning of the movements. And the movement pattern, there will be force, speed, all things will be variable. It should be variable. Then only we can call it the general movements are normal. And those movements generally happens in the axis of the limbs, and these movements are basically rotatory in nature. I mean, there will be rotatory components in all the movements. And the most significant is the elegance. Elegant, the movement pattern has to be the elegance. As I mentioned, that these movements start in the preterm age and last till the 20 weeks of corrected age. But initial post-term up to 8 of 9 weeks till 8 or 9th week with the kind of movement we see is called the breathing movements. Later on, I will show you the video, what are the breathing movements. And then there is a gap of period of say about 2 to 3 weeks when we do not record any video or we do not assess the child as because means there is a gradual start of the fidgety movement. So in that particular period of 9 to 12 weeks, those movements are bit of mixed. So the detection of fidgety movements arrive just after the 12 weeks of corrected age. Fidgety movement gradually emerge at the end of the 9 weeks. Fidgety movements present up to the end of the first year, half year of life, so about 5 months corrected age. And those will be intentional and anti-gravity movements occur and start to dominate after the end of the fidgety movement, as I mentioned earlier. If you can see the video. So if you have seen the previous video, you can see those movements, these movements are much more matured in nature. And the amplitude and speed of the movements are more small and the moderate amplitude. So basically slow to moderate speed. Speed is also slow to moderate. We still not seeing any fidgety movements because this is just after so this child is around 8 to 9 weeks of corrected age, and we are seeing the breathing movements. We can notice the breathing movements. And these movements are also very distinct. If you can notice in the ankle area and little bit in the wrist area, so small rotatory movements are just coming. So those are not very much evident or not sustained. In case of when I show you the movement, the video with the fidgety movements, you can see the rotatory components will be more elegant and there will be more sustained. It's not that coming and going. So there will be the gradual onset of the movement and gradual offset of the movements. Here, these are called breathing movements or writhing movements. Now, when we talk about the normal movement patterns in the general movement, so if there are few other movement patterns also, those are we call abnormal pattern. Why those are abnormal? Because the movement will be very monotonous. You can predict the movement, and those movements will be very abrupt. Those onset and offset will not be gradual. It can be sudden, jerky in nature also. And there will be no variability in the movements. So here we call those movements over-repertoire. So if you can notice, there is a sluggishness in the movements or kind of a letharginess in the movements. But if you see now, see the other one, these movements in this video, these movements are pretty fast and continuous in nature. But still, you can see the child has kept both the limb in a tight fashion, and so there is a component which is basically holding the legs or the limbs. So here this kind of a movement pattern we call cramp synchronized. See how much energy and how much force the child is applying while moving those movements, limbs. In both the cases, this kind of movement patterns are abnormal in nature. Now the fidgety movements. So the fidgety movements are small movements of moderate speed and variable acceleration of neck, trunk, and limbs in all directions, continual in the awake infant except during the fasting of time. That's basically if the child is crying or if the child is kind of sluggy, maybe have just rise from the sleeping mode or just about to sleep. So in those times, we do not generally take any video or we do not assess the child. So if the child is fully awakened and the child is happy, then only we generally assess the child. With this child, if you notice the movements, so there are small rotatory components in the movements. If you notice the lower limbs and both in upper limbs also in wrist, you can see there are small, the acceleration is variable and it looks very beautiful when the child is moving his limbs. Again, this child is around 14 weeks of age. And these movements are called fidgety movements. So if you compare both the child, so with one child, the left one, the fidgety movements are present, and in the right one, you can see the movements patterns are very sluggish, they're very monotonous. So clearly the fidgety movements are absent. Okay. Now, so this is the scoring sheet. So when we assess the child, generally you have seen the many child have wearing cloths. Generally, we prefer the child just with a very minimal cloth, and there should not be any distraction while capturing the video. We generally take a video of 3 minutes minimum. So, and this can be done by any mobile phone also, means a smartphone. And after that, we analyze the video and we score in this scoring sheet. So if you notice the scoring sheet, you can, so there is one section that is gestational age at birth, means we need to first find out the corrected age. So we minus the means gestational age from the 40 weeks. So that is the term age. And then we calculate the corrected age. If it comes in the preterm, so if you see on the left hand side of the scoring sheet, so there are many abbreviations like F minus, then there is AF, then CS, then CH, then there is PR, then H, and there is normal. So those abbreviations already mentioned here. So in case of N, so those are the movements are the normal age specific general movements. M means fidgety movements. H means hypokinosis, means there basically no general movements assessment should be during this during the recording. Means there are, so that is basically the age, as I mentioned, just after the reading movement age till the fidgety movements are coming. So between that 9 to 12 weeks of time, corrected age. PR means poor repertoire. This CH means chaotic. This I didn't mention, but this is a kind of a more abnormal version of the cramp synchronized patterns. AF means abnormal fidgety movements, and F minus that fidgety movements are not present or absent. Sometimes we give this plus or minus thing. If you notice on the right side of the corner, that means this plus minus means that intermittent. Means sometimes those fidgety movements are visible, sometimes it is not visible. So those kind of those kind of scale basically we use in the advanced module. So in this scoring sheet, suppose a child comes at the 36 or 20 or 32 weeks of preterm age, and if we find the GM assessment is kind of a poor repertoire or PR, so in against of that particular column, we highlight that particular box, and again we assess the child after term, say about 5 to 6 weeks of time. Then again we assess if we found that either that poor repertoire is sustaining or not. It can be normal also, it can be abnormal also, based on the child's condition at that time. And that black highlighted portion is basically the age when we do the final assessment. So that is basically whether the child is having fidgety movements present or absent. So this has to be completed. So if the child comes before the preterm or term age and the child is less than 12 weeks of age, so we can do the serial assessments. And we log those data in this scoring sheet. So if you see this scoring sheet, so there is a case. So that was the 28 weeks of postmenstrual age. So you see in the 20 weeks, and then at 30 weeks of time, we did the assessment and we found that there is the movement pattern as CS, means cramp synchronized. Again, we have charted that child at the 33 months of PMA age, means that preterm age. We again and up to, so there are 4 recordings to see. So till the term age, and after term age also we have seen there are one during the post-term age at 2 weeks, and another is 7 weeks. And the final video we have taken, our final assessment has been done at the 11 weeks of corrected age. And we have found the fidgety movements are absent. So later on we found the child is dyskinetic cerebral palsy. So this is how we can relate or find or predict whether the child can have any neurological deficit or cerebral palsy later in the life. This is another child. Here also we have taken the previous one, there was the movement pattern was in the cramp synchronized, but here the movement pattern was poor repertoire. If you see there, the columns are mentioned in the PR, means poor repertoire, and we have taken 6 videos, and the final video has been taken in the 11 weeks of time, and here also we found that fidgety movements are absent, and later on we found that child is having cerebral palsy and spastic in nature. So these are now there are evidence that it shows that evidence has tell us that lots of research studies has been done on this general movement, and this qualitative assessment of general movement has been shown the better predictor of neurological outcome than the other traditional neurological examination in brain damage preterm infants. So this is the longitudinal study of 130 infants. So there are this has been seen by the ultrasound findings at the preterm and the preterm age and the post-term age. And we have found, so this is the data. So which kind of a movement pattern which leads to cerebral palsy, or the kind of movement pattern can leads to normal also, or mild neurological deficits. So basically, when we see the movement pattern are cramp synchronized in nature, they have very lesser chances of developing normal movement patterns later. But those with the poor repertoire at the very early stage can also develop normal movement patterns at later in the life. Means they can have very less significant problem later. So there are also and those, whether those movement patterns are significant or not, so that we can assess by the advanced module of the general movement, where we assess there is a chart called motor repertoire or the optimality score. So in that optimality scale of 5 to 28, we measure the child's quality of movement. So if the optimality score is between 24 to 28, then we can say the child have the child will have the typical development, or the developments are typical in nature. If the optimality score is less than 15, so there is definitely a chance of having cerebral palsy later. If the this optimality score is above 20 but less of 24, so they will have the probability of developing other neurocognitive disability like autism or learning disability or any other form of disability, but not the cerebral palsy, or they will have the less chance of developing cerebral palsy if they do not receive any kind of intervention from the very onset. So there are lots of studies, and this particular study predict, because why this general movement assessment, we call it game changer, because this is the only evidence-based tool available at this moment which can predict cerebral palsy with 98% accuracy, even better than the MRI and other imaging, neuroimaging imaging or ultrasound. And it has a sensitivity of 97 to 98% and specificity of 89 to 91%. So those are the superior to cranial ultrasound and the other neurological examination, including Hein and other assessments. This I think Dr. Bhattacharya can discuss when he will share his presentation. So now the importance of this thing, like if you see this child, This child was admitted in our hospital with high bilirubin at the age of 6 days after birth. We did the general movement assessment and we found the optimality score of 12. But they have started the early intervention straight away just after the once the child is discharged, or the child was even in the NNICU, and we started the treatment. So we have salvaged the child quite a lot. So that leads to basically now the child is able to walk and climb stairs, and so basically the GMFC score of 1. So this is all about the general movement assessment. Now I request Dr. Bhattacharya to continue his presentation.
Thank you, Jewel. I think you have given us an overview. So what I would like to do is that if you stop sharing your slides, I can share mine in that case. I hope I am also a host. So I'm going to share mine now. Yeah, good. So can you see mine?
Yes, sir.
Thank you. So how do I make the videos on? Hold on. I have to. So video should run, right?
So you share the screen and then run it in the slide mode.
Yeah.
And we'll
Okay,
let
then.
you know. Yes.
Thank you. Right. So basically, you all have heard Jewel mentioning about the high sensitivity and specificity of a clinical tool which can predict cerebral palsy at birth. So when we say early intervention, how early is early? Basically, we are saying we should assess them at birth. So there are some risk factors like prematurity, low birth weight, high jaundice, and all those things. Why this is important for India? Because we need a clinical, easy to do clinical tool which can be trained to any healthcare professional. So this is a mix of doctors, physiotherapists, nurses, psychologists. So there is a huge range of people who are involved in this training. Anganwadi workers, ASHA workers, we can train them. We can definitely train them in the basic general movement assessment. The pictures here are showing advanced general movement assessment training that we did subsequent year. And here is this evidence which basically says in JAMA Pediatrics 2017 video sort of publication, which is basically saying that every neonatal unit must equip themselves with this easy to do tool. Why is it easy? It's very easy to do because it takes only 3 minutes of optimum video, which can be trained to anybody. So this is one. Number two is that, if you are advanced trained, you can also do what Joel was saying, optimality score. So a normal score is 28. If your score is between 25 and 28, you are at low risk. So you can say your chance of not having any neurodevelopmental disorder is very high. However, if it drops below, say 25, then the early figures, like, between 25 and 22, you can think of things like, learning disability in the future, autism, and global developmental delay. Those kind of problems you can predict, and we have cases where that has happened also. Less than 22 is where you are thinking of motor disabilities, and this could be subtle fine motor disabilities, and by the time it is coming in the range of 15 and 12 and all those things, you know that this child is going to be cerebral palsy. And Jewel has also mentioned about serial measurement, which will tell us exactly how the child's progress is going to be, and they are so predictive. If you think of even case of, say, autism, how much can you predict a child's risk of autism at birth, or by 3 months of age, or by 5 months of age? Compared to that, a 67% predictability is like huge predictability. And if you can put the early intervention, then you don't have to depend on machines. These are machine sort of learning. AI tools are being currently developed by Graz University, where Prechtel or Preschel used to work, and Chris Steinspeiler, whose photography you have already seen, used to work with Professor Prechtel. So these are the AI generated movement that can be accurately predicted. So how much writhing, how much fidgety movement, how much hypokinetic movement. Everything is completely collectible, and with the data you can actually predict. So this is something that Megha has actually collected in European Academy of Childhood Disability in Slovenia. So the sounds are not important here, because what you are going to see is what is the world moving towards. So world has moved now towards, this is from Graz University and their network of people from GM Trust International. They have now come up with this early neurological deviation detection. So you can understand, what Jewel was saying, that by kind of 3 to 5 months of age, a child moves nicely and elegantly. If there is any jeopardy in that, the other normal looking child who was a little hypokinetic, only through GM assessment you can tell that whether that is child being a bit generally lethargic and being sleepy, or the child is actually pathologic. So that way, if you are doing this risk detection, machine can do that for you also. But for places like India, I think it's going to be even far more costly than what will happen if we do that in the way we are on about. And that is why what we need to do is to do early intervention. So this is now what we are going to show you is in Barcelona, European Academy of Childhood Disability. We had a symposium, and that's what I want to show, the results of early intervention. What happens with early intervention?
So audio is not audible.
Okay, then it's no point. So I'm going to the next one. This is where audio is not audible. So I'm going to talk. Then subsequently, again in Slovenia, we had a presentation. So we had 15 posters selected, one oral presentation selected, and one instructional course. So this is the oral presentation where, Megha and Sreyoshi from our institute has gone there and presented. So they have presented about family clustering, about all this thing in with psychological factors. So basically what we need to understand is that, the neural plasticity, this is a video that we have captured in 2023, where we are showing how nerve inside our brain selects which neurons they are going to go connect. So the neuron is making decisions, and the decision is influenced by various factors like, epigenetic factors, early childhood experiences, and the microsystem and mesosystem. So this is our team, Kolkata developmental team from Kolkata. We were all over the place presenting about all these things that we do, where we were showing how much we do in terms of early intervention. 85% of our children go to normal school. So this result I would like Megha to tell, because but what is very heartening is that now Indian Academy of Pediatrics has actually adopted this GM assessment for their risk stratification assessment, clinical monitoring, early stimulation in high risk neonates, which is called RACE module. So Kolkata developmental model, I would invite Megha to present, so that we know about the results of our early intervention model. So over to you, Megha. If you could just tell us about basically our results of Kolkata development model in brief.
Sure, sir. Do you want me to? I think do you want me to share the video? I guess we
Yeah,
should
please,
show the
please.
video.
Yes, please.
Yeah, I just hope it will give me a second. Mm.
Presentation mode.
Do let me know if the sound is
Parents
visible
through
from
a
here.
standard structure universal practice model
Audible.
of prevention called
You have to click it again.
Kolkata development model. The author is Anjan Pathanamthitta from India. I don't know if I say your name properly.
All the presenters, because we have got a team who will present. Shreya Ghosh, who was our intern and then now is a psychologist who will be doing the presentation, and her teacher, Sreyoshi Bhattacharya, a professor of Calcutta University. So over to you.
Good evening, everyone. I'm Shreya from India and I'm a psychologist. So, the title of my project is Lived Experience of Parents through a Standard Structured Universal Practice Model of Intervention, the Kolkata Development Model. What is this Kolkata Development Model? It's an universal care pathway. It's standard, and it is for any special needs children of any degree of severity and of any age. This is what the schematic representation of the Kolkata development model. Let me take you through this. Kolkata development model, the first thing or the point of contact in the CDC is through referrals from OPDs, followed by referrals from communities and from NICU, other general movement assessments. After that comes the initial contact with the developmental pediatrician, followed by an intensive parent training program of minimum 7 days, followed by which the children or the child goes through screening, followed by routine health checkup, standard assessments, and then the multidisciplinary therapeutic intervention. During this standard assessments and multidisciplinary therapeutic intervention, a goal is set, and after that multidisciplinary feedback sessions are there. What one of my fellow presenter has presented in her presentation before me, that there were the therapists do not communicate with each other. This is the solution for that multidisciplinary model. So this whole loop of screening, standard assessment, multidisciplinary therapeutic intervention.
Mega, it looks like it's not running. You might have to click it again.
Okay.
Of parents through a standard structure
And you go to that middle part.
Followed
Yeah.
by referrals from communities and from NICU, other general movement assessments. After that comes the initial contact with the developmental pediatrician, followed by an intensive parent
I guess you
training
will have to do it.
of minimum 7 days. Assessments.
So the video is up till here only. Am I audible?
This is the solution for that multidisciplinary model. So this whole loop of screening, standard assessment, multidisciplinary therapeutic intervention.
Yeah, I think Megha, you better do the results.
Okay. So
Sorry about that low bandwidth.
that's all right. I guess it's because of the internet or something. So yes, the one who was presenting, she is Ms. Shreya Ghosh. She is one of our former psychologists at CDC Apollo, and currently she is doing her PhD at University of Pavia, Italy. So this she presented this at Barcelona, and our statistics were that the study was done on 446 children, and out of which 85% went to normal schools after 8 months of intervention. On an average, 8 months of an average intervention, they went to normal school, and their problem range were from mild to severity. So it's not just that only one like mild or moderate were there. From mild, it was still severe, and after 8 months of intervention, on an average, they went to normal school, 85%. So would you like to add something to this?
So, and nearly more than half were on the severe range.
Yes. Yes.
So basically, that is what it is. And this year, we were invited with 7 posters, 3 oral presentations, and 2 instructional courses. But the EACD is running today, and we are not there. We are not in Belgium, unfortunately, but for other reasons. But what is important is that if you detect them early, and if you institute a high quality, scientifically based, intensive early intervention program, the children normalizes almost inevitably. So this entire concept that these children are disabled or they have to live a life of disability and we just rehabilitate them or just habilitate them or whatever is kind of goes out of the window, because we can do much better, and we are doing it in Kolkata, sitting here in Kolkata. This year actually they have asked me to chair one of their oral session also, which I could not attend. The reason is that the quality of the work that we are doing, this is a model for the country, just to understand that we must detect them at birth, because we have the clinical tool. And who better than National Neonatology Forum to push it forward? Neonatologists are at the heart of this whole thing. So first of all, they need to get trained. So my appeal to all neonatologists will be, the doctors, is that please train yourself in both basic and advanced module. So doctors should all be trained in both basic and advanced module. All other healthcare providers, they can train themselves either basics or basics and advanced depending on their level of mentation and abilities. But basic they should all do, because this is a sure shot early detection, early prevention, disability prevention tool. Because our anecdotal evidence right now, we haven't got enough cases at the moment just to pull up and have a study designed at the moment, just to see what is happening with the early detection ones. The ones who we are detecting early and instituting our management, so far what we have not seen one child getting into the zone of pathology. All of them are getting out of the zone of pathology even before they have entered the zone of pathology. So just relate these to your medical experience, that children with a sort of spastic cerebral palsy coming at the age of 1 year, just a little bit of spasticity developing, you are trying very hard, but they still have the residual problems. Just imagine, and you thinking that oh my god, I wish they should have been coming to us a bit earlier. But But how could they come? They don't know there is a problem because the problem is not showing. This is what is the called asymptomatic stage risk detection. And that is where GM assessment makes huge difference. The entire burden of childhood disability is mainly in countries like India and China. In cerebral palsy, we know that that burden is 80% of global burden. So if not us, who? Yes, we can do those AI generated stuff as well when we have enough money, and we are going to have enough money. So we'll do that. But what about remote places? What about resource crunch places? GM is the answer. You don't need anything, but you just need a clinical training, training at the highest authority. This training part, I would insist and urge that if you do not take it with the highest authority, the quality of training is not good enough. So we always have taken our training from Krista Inspeiler. As long as she is alive and she can deliver it, I would suggest that we take it from her. Then we will have to be forced to take it from sort of lesser trainers, but they are no less. They are international trainers as well. But we will do that. But for the moment, my suggestion would be, while she is still capable, India really needs to learn from her as fast as they can, because the whole world does. When we ran this advanced GM course in about, combined course was about 300 or 500 pounds. The same course, basic course was ran in University College of London right after us, which was 900 pounds. Advanced course itself separately is 990 pounds. So there were 6 countries, people from Germany, Australia, I forgot, 6 countries, people came to Kolkata to get this training and accreditation, because if you get that accreditation, that's a worldwide accreditation. So they came here because they are coming and going and staying, and everything was taken care of in that price. So they could visit India as well. They get the certificate and got trained in the right heartbed of cerebral palsy. India is a hotbed of cerebral palsy. So they came here and they saw the cases and they learned about general movement from India. So this is what we are urging, and we really want National Neonatology Forum, just like in Indian Academy of Pediatrics, but we can't do without the National Neonatology Forum also joining hands to do the race, to do the risk stratification. That's our point.
Thank you, sir. Thank you, sir, for the brilliant presentations. Actually, very insightful. And like we see that, like you said, the neonatologists are somewhere in between from the development and the babies. So we sort of have to relay these babies to whenever we feel they need more help and further help. And that's where we get stuck, whom to send and when to send. And the perfect person to elaborate on this and probably put more insight. So he's been working in this field, Dr. Naveen sir. Can you give more insights onto this?
Thank you, the team of IAP and NNF, to bring in the horses to us. Dr. Anjan, Dr. Jewel, it was a lovely presentation. We have heard previously presentations on GM, but the clarity was so good that it made it look so easy. But believe me, to the audience, the art of training, art takes a lot of time. The general movements are, as the name suggests, movements which are not with a particular purpose. So first thing I want most of the colleagues who are in the hall to know that we record these movements in the first 5 months of it. After that, these general movements are replaced by more specific. The beauty of this tool is two. Number one, even a 32, 33 weeker has patterns of movements that can be recorded. And no other tool is available which can start looking at babies so early. And the second thing is it requires only a video recording and is the most non-disturbing assessment. But just like Dr. Anjan said, training from the masters. If you want to use a simpler tool and don't have the AI with you, then you will have to go to looking at what the Hammersmith tool team has done. They have borrowed the concept with permission from the GM group, and they have taken what is called as quantity and quality of movements into their assessment tool. So at least for those who cannot train immediately, there are two appeals which Dr. Anjan made. Number one, please try to stratify, try to find out which babies who you're leaving your ICU are at increased risk. And then look at two things. Are the quantity of movements the same as you expect? Are they less? Are the quality of movements? It's called as variable movements. The cortex of our baby has ability to generate variable movements between the hands, legs, and also different patterns which we use. So with this brief summary of what we heard, I would invite questions from the audience.
Absolutely. I mean, what a fantastic and simple and lucid explanation. Thank you, Dr. Arun, for letting us speak. So if there are any questions we can take, but I think we are over the time. I don't know what you all want to do. You
Sir,
got a very good participation.
can I ask
Sure.
a few questions on behalf of our audience who may be shy? As audiences, we are always shy to expose ourselves. But we had a 2-day workshop from Vellore team about few years back, and we found at the end of the workshop what looked very easy to the trainers. To us, when they showed us the normal one, we thought it is abnormal, and abnormal when we found, we were very excited throughout the workshop. At the end, this gestalt science of looking at a baby, how do you artists do it?
So gestalt only comes when we have seen lots and lots of babies. But first we need the training, as you have said, that normal babies look abnormal, abnormal babies look normal, and that is why we need the training. Once we have the training, the trained eye, we cannot allow them to rest. If we let them rest, it's just like doing the phlebotomies and venipunctures. We will run out of our skill within 2 weeks. Studies say that, if senior house officers do not do those things for 2 weeks, they go on a 2-week holiday, come back, they don't do it as good. Same thing here, and that is why Jewel has been constant since that moment. From Kolkata, we were 5 people who were trained, and from our center, we were 3 people who were trained in advanced GM. But Jewel has continuously kept assessing, and that is why his internal consistency is so good. I haven't been able to keep up with him, so I have dropped off. I don't do it myself anymore. Jewel does it for me because his scores are. He has cross-checked with the GM trust also. It's always consistent, and his optimality scores are exactly the optimality scores that they are doing. So please aspire for that. I mean, as doctors, we should aspire for that. Young doctors, this is such a wonderful and new thing to do. I mean, time to get excited about it. A clinical tool, a cheap tool, a easy to do tool. All we need is a training. And for that training, we need to invest our time. When I hear that we don't even have that time, that is when I feel so despair. This I cannot believe that this is something that we are telling that it's so easy to diagnose. You will do it, you will do it in your own clinic, and all you need to do is to get this training. 3.5 day of basic, 3.5 day of advanced are minimum necessity.
Anjan sir, sorry
we
to
we we
interrupt
did it
you.
over 10 days. We did it so well. Sorry. Yes.
Yeah. So one more question. When we were reading and literature as a part of trying to write guidances for our own neonatology group and pediatricians, one of the important messages I noticed that 12 weeks when the fidgety movements start coming is the time when the GM's accuracy starts becoming what is called as permanent or tracking. And before that, when we do the GM, there can be improved accuracy in classifying babies, but its sensitivity and specificity becomes very accurate after 12 weeks. So your comments, please.
And Jewel has shown that in that slide. So Jewel, please explain that. Please bring up that slide, because you have shown that how beautifully you have shown. It is all in that slide, that how people are going from abnormal to normal, normal to abnormal, and only in the 12 plus we do the confirmation. and that is why in his slides he has shown those scoring sheets, which is serial. Why? Because first time you do before 12 weeks, you are doubting it. Second time you are now suspecting more and more and more, and then only at the 12-week time you are just confirming it. So this is the thing.
Yeah,
Go on, Joel. Yeah.
basically before the 12 weeks and between that 9 to 12 weeks, the kind of movements are kind of they're mixed. And sometimes if you assess or see that child, and that age has to be the corrected age of 9 weeks to 12 weeks. Many times, if we when we see the child, hardly there are kind of any movements, or you can say the child is not moving that much, or the very sluggish pattern of movements, and it is very much means possible for the clinician or for the examiner to misread the movement patterns, that they are either the child is have the poor repertoire or any other abnormal kind of thing. So that's why the guidelines is very clear that, and this is the physiological thing that about the I mentioned about the central pattern generator and other thing, that those fidgety movements just comes after the 12 weeks of time, and from 11 weeks onwards it's visible, but it is more prominent after the 12 weeks. And best what I have seen in my practice, the best time is 12 to 16 weeks of time frame, not even after 16 weeks. After 16 weeks also, because the other kind of a movement patterns overlaps with the thing. So that's why that fidgety movements can be misread with other, like there will be swipe movements, there will be turning and head turning and many other things. So that's why the best possible time frame or I suggest is 12 weeks to 16 weeks, which is basically 3 to 4 months of corrected age.
So if I may just add a very quick point that, if we want to develop a policy about it, right, we should make it a routine practice, just like universal hearing screening, neonatal hearing screening, and universal neonatal screening. We must have this as a universal practice. If we did that, all problems will go away.
I think the best part is that it's just taking a video. So there will be some nitty-gritties once that people are trained. So they will be knowing when or how much to take the video or when not to take the video, because that is the only wonderful thing. And you can, it's not mandatory that you need to score the assessment at the right after just taking after the video. You can do it later. That's why you need to secure the video. And yes, you may have to go through the video. Initially, I have to go through, I think, more than 50 times. And previously that Dr. Bhattacharya mentioned that gestalt perception thing. So we are not concentrating. But yes, when you do the advanced thing or optimality score, we have to concentrate on the need the integral part of that whole thing. That whether it is movements are present in trunk, neck, limbs, the speed, the modulation and everything. But those can be seen once who are trained actually.
Thank you, sir. Thank you so for that wonderful thought. The presentation has been brilliant, and like as a neonatologist, I feel this sort of gives you an insight of how easy it could be for us to assess, than rather than have a mental block about having to assess that a neurologist or a pediatric neurologist has to assess a baby with a developmental delay, and this would easily give us, and then we can refer them to the respective persons depending on how the movements are, and it is a very easy to use tool. And plus, if you go wrong, it can always be rechecked, because if it's a video, it can be always rechecked by the senior person. So I think this is something which can be easily applicable to routine practice, especially neonatal units dealing with high risk babies. I think that is something which we can look into. And like sir said, already policies are on its way, and it would be the right time where you look for hearing assessment, ROP, and this should be something that should be made mandatory, in fact. Thank you,
Yes.
sir, for that wonderful
Yes.
presentation. And I would like to say there is a feedback form for all of us to fill, and very kind if everyone can look into it and then fill that. Thank you, sir. Thank you, Anjan sir.
Thank you very much.
Thank you as well, sir.
Thank you, Anderson.
Thank you, Naveen sir, for the thoughts. It's always
Thank you.
nice to have you with our team.
Good night, dears.
Good night, sir. Good night.
Thanks, everybody. Thank you.